Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, HPV Primary Screening, What, Why, and How, FDA and Interim Guidance. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on June 30th, 2016, and 2 years for social workers, expiring on June 30th, 2017. I'm Nancy Wright, Director of the Division of Cancer Prevention and Control with the Alabama Department of Public Health. And I would like to welcome Dr. Grace Thomas, the Department's Assistant State Health Officer for Family Health Services, who will introduce our presenter today.
Thank you, Nancy, and good afternoon. It's a privilege and an honor to introduce today's guest speaker, Dr. Werner Ha. Dr. Ha is a professor and division director of gynecologic oncology and the Margaret Cameron Spain Endowed Chair in the Department of Obstetrics and Gynecology at the University of Alabama at Birmingham, and a senior scientist in the UAB Comprehensive Cancer Center. His research interests revolve around screening and prevention of HPV-related diseases, as well as novel immunotherapeutic approaches for pre-invasive disease of the cervix, as well as cervical cancer. Dr. Ha has authored and co-authored over 150 articles, including numerous publications in the areas of prophylactic HPV vaccination and guidelines for the management of abnormal cervical cancer screening tests and cancer precursors. He is the principal author of the recently published article, Use of Primary High-Risk HPV Testing for Cervical Cancer Screening, Interim Clinical Guidance in the Journal of Gynecologic Oncology. Articles authored by Dr. Ha have been published in world-renowned medical journals such as the New England Journal of Medicine, the Journal of the National Cancer Institute, Lancet Oncology, and the American Journal of Obstetrics and Gynecology, to name a few. He currently sits on the board of directors for the Society of Gynecologic Oncology and the Executive Committee for the American Society for Colposcopy and Cervical Pathology. Dr. Ha is a member of the National Comprehensive Cancer Network Cervical and Uterine Cancers panel. Today's talk, titled FDA and Interim Guidance, HPV Primary Screening, What, Why, and How. Welcome, Dr. Ha.
Great. Thank you, Dr. Thomas, and it's truly an honor and privilege to address you all, and I want to thank the Alabama Department of Public Health for this opportunity. So we're going to take the next hour or so to talk about the role of primary HPV screening, what those benefits are, and some of what are the potential disadvantages. But I think, as you will recognize through the course of the talk, we have a lot of work ahead of us in terms of continuing to screen and prevent cervical cancer, not just in this state, but nationwide and worldwide. So this is a highly simplified diagram of what we know as the Affordable Care Act, also known as Obamacare, and I think it's actually quite ironic that as of today, the Supreme Court actually upheld the subsidies for health insurance under Obamacare. So yes, this is still very much in play. But as you can see, there are lots of moving pieces, but one major piece in this is highlighted in the circle in orange is AHRQ for the Agency of Healthcare Research and Quality. This group actually sets forth standards related to screening, and one major component of ACA is that every person who in the United States should be eligible for free screening, or screening that doesn't have a copay. Under that obviously includes cancer screening, and of that obviously includes cervical cancer screening. And so screening is a major component of modern healthcare today, but I wanted to give you an idea of the many moving parts. But again, the talk essentially revolves around screening against cervical cancer. So as a part of my disclosures, I do serve as a non-paid consultant for Roche Molecular Systems, and you'll understand why this is important. So I'm actually over-disclosing this, but I think it's important for the audience to understand what work has been done with this particular company. And I also serve on the Scientific Advisory Board for Merck for their 9-valent vaccine, which is just recently FDA approved. And we'll talk about this a little during the course of the presentation as well. So really there are 3 primary objectives related to this presentation, first of which is to review the known benefits and some of the limitations associated with cervical cytology. For those that don't know what that is, it's also known as the Pap smear. To review some of the scientific evidence in support of HPV testing as a primary screening test. And then lastly, to talk about how do we screen for women or girls who have been previously vaccinated. And so this is the third objective, is looking at perhaps the next 10, 15, 20 years in terms of the role of screening in this country. And again, as a parallel to that, in terms of the topics that we're going to cover, I think what you're going to recognize is that cytologic screening or Pap screening has really served as the paradigm for cervical cancer control in this country and many developed nations worldwide. It's really largely served as the standard for all cancer control, whether it's breast cancer screening, colon cancer screening, prostate screening. What we've learned from cervix cancer has played into the other diseases. And unfortunately, what you'll also recognize is that with cytologic screening, at least in this country, has been very much glory for some and failure for many. And what we recognize is still yet in 2015, a lot of women who get cervical cancer in this country unfortunately have not been screened or have been inadequately screened. And so we still have a lot to do. The second is really to talk again about the rationale, burden, and proof for HPV DNA testing. And lastly, talk about that post-HPV vaccination era and what that looks like, and do we need paradigm changes now to accommodate for that. So it all started here. With Dr. Papanikolaou, who published his seminal paper in the Gray Journal, also known as the American Journal of OB/GYN, in August of 1941 with Herbert Trout. And Herbert Trout was a well-known gynecologist at that time back at Weill Medical College in New York City. And since that time, a lot has changed in regards to cervical cancer screening. So you're probably wondering who the gentleman is in the bottom left and the bottom right. And so that gentleman is Eduardo Franco. Eduardo Franco is a very good friend of mine and actually is an epidemiologist who has dedicated his entire career to HPV and actually currently serves as the Cancer Center Director at McGill University in Montreal, Canada. He was actually in a meeting in Turkey, which is on the upper right of that map, and actually rented a car and drove all the way down to the village of Kimi and the island of Evia to pay his respects to the person that really changed his professional career. So on the left is a bust of Dr. Papanikolaou, and on the right is literally the home that he grew up in. So there are actually 2 really good biographies on Dr. Papanikolaou, but a couple things I want to point out that I think are relevant from a historical perspective. One of which is Dr. Papanikolaou was, he was trained in Munich, Germany. He came to the United States looking for a job. Believe it or not, he actually played the violin at restaurants to make money at night, to basically feed his wife and his family. Ultimately got a job at Weill Medical College to look at the menstrual cycle of guinea pigs. And so guinea pigs don't menstruate, but in order to know where they are in the cycle, you actually have to do what's known as a vaginal smear. And on that vaginal smear, you can determine where they are in the cycle. It's not unlike a maturation index where many of the OB/GYNs prior to the world of FSH and LH, that's how you determine what part of the cycle you're in. So he was able to extrapolate those findings in humans, specifically women, and use it as a diagnostic test for cervical cancer. So I think it's a really great story, and I think what's unfortunate is you can't give people who have passed away the Nobel Prize. And so unquestionably, if he were still alive today, and if we had truly appreciated and recognized his contributions to women's health care and cancer control, he would have easily won the Nobel Prize. So I think he really serves as the grandfather for cancer control worldwide. But there's a person who doesn't get credit for this. And I'm very much a firm believer of giving credit where credit is due, and that person is his wife. So Mrs. Papanikolaou, Mary Papanikolaou, actually served a couple roles that I think are really important historically. One, she was probably the world's first cytotechnician, okay? Two, probably the first woman ever to get a PAP, okay? And three, this is like probably the factoid of the day, is that she actually underwent a PAP every day for 20 consecutive years. Okay? That was her dedication to science. Okay? And as a consequence of that, she was actually awarded a Medal of Honor from the King of Greece, recognizing her contribution. So realize that it's not just Dr. Papanikolaou, but it was really a two-person team. He and his wife, as well as Dr. Trout, who I think doesn't get enough praise as well. But Dr. Papanikolaou clearly has changed the landscape of how we do cervical cancer screening in this country, and what you'll see shortly is it's had an enormous impact. So when you actually look at what the impact of cervical cancer screening is, so this is a paper that was published by Dr. Quinn and Bia in the British Medical Journal. And the UK actually has a very different cancer screening program. It's called a National Call Recall System. So basically, women have to get screening, and when they have an abnormal pap, they get brought in, they hunt you down, you go to a specialized colposcopy center, you get biopsy, and you get treated. And that National Call Recall System was introduced in 1988. And so you know, that system doesn't exist in the United States. What we have in the U.S. is known as an opportunistic screening program. Women don't have to be screened. Even if they had an abnormal screening test, they don't have to come back in. And that's one of the problems that we have in this country. But when you see that it was introduced in 1988, after that point, what you see is as coverage increases from the 40% range to almost the 90% range over that time period, you see a likewise plummet in the incidence of cervical cancer. And so this is one example of many of what happens when you introduce a well-organized screening program in the UK, or any industrialized nation for that matter, and what happens to the rates of cervical cancer. So for the audience, a couple things I want you to recognize, one of which is not every country can do this, and we're going to talk about this a little later at the end. But two, that again, you know, when you look at the invasive cervical cancer rates, in 1941, in that article that I just presented to you, the annualized incidence of cervical cancer was greater than that of breast cancer in this country. Okay? More women were diagnosed with cervical cancer and died from cervical cancer than they saw with breast cancer. That is the impact screening has had in this country, and in certain parts of the world, including the United States, we have seen about a 75 to 80% drop in cervical cancer incidence. So it's been really quite dramatic. But still, we have problems, and that's where I want to go to the next part of this talk. So how good is the PAP in terms of cytologic screening for cervical cancer? Well, so what we know is it's probably not a very good test. And so back in 2000, Dr. Nanda, who was at Duke, and her paper was now famously known as the Duke Report, demonstrated that the sensitivity of a PAP is about 50%. The specificity was quite high, it's about 98. But let me talk about sensitivity and why that's important. You know, if you're in public health, you know all what these words mean and their relevance. So sensitivity, to make it easy, is a reflection of the false negative rate of a test. So really what sensitivity is was 1 minus the false negative rate. So basically what this means is that when you have a test with a sensitivity of 50%, that means that your false negative rate is 50%. And it's kind of easy to remember because there's an N in negative and there's an N in sensitivity. And this is how I've always remembered it since medical school. And so, likewise, Jack Cusick, who is an epidemiologist in London, published a pooled analysis of both mainly European and Canadian studies, and again demonstrated that the sensitivity is about 50%. So what that means in essence is that the false negative rate is going to be 50%, and it's about the equivalent of a coin toss, right? And so you're wondering, if it's that bad, then why are we using this test, and how have we made such a huge impact? Well, the reason we've made a huge impact is that we've demonstrated that when you have normal serial screening, the sensitivity of that actually goes from 50% to as high as 75%. We have 2 consecutive annual PAPs. And when you have 3 consecutive annual PAPs, it goes to as high as 90%. Maybe even a little bit higher when you use things like liquid-based cytology, and realize that this analysis was done when we were using the traditional glass slide and using hairspray. So we've had some gains during that time period, but this is where we've made the difference. We've made the difference about annualized PAPs and the increase in sensitivity as you have consecutive normal cytology. That's the reason why that this has worked and works so well. So other things to consider. Well, one thing that many people have published, we published this through the ALTS trial, through UAB, when Dr. Partridge was in my position and served as one of the major PIs for that large study through the NCI. Other individuals like Tom Wright, who has published extensively on the guidelines, has published this as well, that it's a highly subjective test. And what we know in 2015 is that if you take a PAP and you give it to 10 different cytopathologists, don't be surprised if you get 3 different results. It happens all the time. Not only that, if you took the same test and actually gave it back to the lab and asked them to read it, don't be surprised if the interpretation is different the second or third time around. So that's one of the problems, that it's highly subjective. The other thing that's a big deal, and this is one thing I want to stress with this group, because we're entering this world of precision medicine. It's precision medicine and precision risk. So it's not so much about whether you have disease today or don't have disease. It's about your future risk of disease 1, 2, 5, 10 years down the road. And the PAP is unable to do that. The PAP is essentially a Polaroid of what a woman's cervix looks like today. So you can only comment on what the disease status is today, not what the disease status is going to be 6 or 12 months from now. And that's one of the things that I'm going to espouse specifically to high-risk HPV testing. And again, lastly, we're not going to know how PAP cytology works when women are vaccinated. Okay? And one thing I'm going to talk about later is the prevalence of disease. And for those of you that understand this, when you have a very prevalent disease, that positively impacts on the positive predictive value of your test. However, on the flip side, if you have a disease that's fairly uncommon, then it affects the positive predictive value in a negative way, and that predictive value actually goes down. And I'm going to give you a classic example why this is clinically important. So of all the slides that I'm going to show you, this is one slide I really want you to spend some time thinking about. Okay? This was a paper that was published by Joachim Dillner. Joachim Dillner is an expert in HPV and screening from Sweden, and he published basically aggregate results from multiple European sites, and basically looked at time zero. And these are women that have a normal test on entry, either normal PAP, negative HPV, or normal PAP and negative HPV. And what you'll see essentially over a 6-year window, what their cumulative incidence of developing CIN3, what we define as a true precancer, or worse, cancer, is over time. So a couple things, one of which is that you see a clear-cut linear rise for cytology. It's that bluish-purple curve. It's a straight-up rise, like a 45-degree angle, in terms of women who acquire and develop CIN3 with a completely normal test on entry. Okay? It's scary because when you think about it, at 12, 24, 36 months, the current recommendation in the United States is to screen every 3 years with cytology. It's kind of scary that 40% of those women at 3 years wound up having CIN3 or worse. Okay? It's impressive when you think about it. Likewise, the other thing I want you to recognize is the red curve and the green curve. So the red represents women who are negative for HPV on entry, and the green represents both normal PAP and negative HPV. And what you see is you don't see the same kind of rise over time. However, what's interesting is how close those two curves are. Those two curves are basically almost, you can't separate them. The only reason we can separate them here is I basically expanded the y-axis, but they're very close. And so this paper really addressed the concept about whether or not, how much does the PAP add above and beyond a negative HPV test. And so one concept that you're going to hear over and over in the next 30 minutes is what really drives a negative screening test in co-testing, PAP plus HPV in women 30 and older, is not the PAP. It's the HPV result. And I'm going to show you U.S. data to kind of further hammer that point. So how is HPV testing currently used in the United States? So I'm going to talk about 3 mechanisms. Okay? These are all being currently utilized, some much longer than others. So one is serial. And so what we use is that almost every site in the United States at this point utilizes HPV testing for triage of ASCCP cytology. That equivocal test, you don't know what it is, and the recommendation is you have an ASCCP pap, you get an high-risk HPV test. If it's positive, for the most part, you get triaged to colposcopy, except for you're young, and that's the only major change. So this has been around for a while. This is actually directly a byproduct of the ALTS trial, and so this state is actually one of the very first states to actually embrace and adopt this type of testing. The second is parallel testing, also known as co-testing. I talked about that earlier. So in women 30 years and older, you can actually combine a pap with an HPV test. The initial paper was published by Tom Wright in 2004 as interim guidance, and this has been approved by multiple professional societies, as well as the American Cancer Society, as well as the United States Preventive Services Task Force, of which their guidelines our health department follows quite closely. And again, as you know, if they're both PAP negative and HPV negative, then you get screened every 5 years. And that was a major change that was published in 2012. It's the last one that I want to spend the most time on, which is another form of serial testing, but it's basically, instead of using a PAP, an HPV test as your primary test. I'm going to show you the data, and then I'm going to talk to you why this is a better way to do screening, at least in this country. So I don't want to spend a lot of time on this, but it's interesting. Having served on publication committees and scientific advisory panels for the HPV vaccine, those studies have actually turned out to be great studies for the natural history of the disease. And so what we knew originally, and we thought originally, was you go from normal to CIN1 to CIN2 to CIN3 to cancer. Well, what we've learned in the last 10 years, it doesn't quite work like that. We've seen patients who develop an HPV infection and can go straight to CIN3 in under a year. And so we used to thought that that takes place over 10 years. In reality, it takes very little time to develop that, okay? So a couple things on this slide I want to point out that are really important teaching points here. And this is important how you counsel your women. Yes, it's a sexually transmitted infection. But what's key here in terms of the risk of getting cervical precancer and cancer is not that isolated HPV infection, but what we call persistent infection with the same type, particularly with type 16 and type 18. That is the genuine independent risk factor for cervical cancer. So there are millions, on the order of 20 million women a year who have an incident isolated HPV infection, none of which, or very few of which, will ever go on to develop cervical cancer and ever develop a clinically significant lesion. So we need to start re-educating our patients and the women in the state that getting HPV in reality is not a big deal. You're not going to die from it. However, if you have persistent infection, the risks do change dramatically. Okay? When you have a persistent infection that's at risk for developing a high-grade lesion, okay, and again, we thought that that might take, 10 years. In reality, that could be over months, and that time frame is very short. And then the time to go from developing a precancerous lesion to cancer usually takes place over years. Okay, and so I've said this before in this room, in fact, many years ago, but this is the reason why in this state, we have coined cervical cancer as mama's disease, right? And you probably have heard me say this before. The reason we call it mama's disease is when was the last time that woman saw a patient, or saw a physician for their care? When they had their last baby, okay? So they have their last baby, maybe they're on Medicaid, it expires at their 6-week postpartum visit, they get an abnormal pap and they never come back, or worse yet, they never get screened. And so I can't tell you how many women I've cared for who come in their late 40s, have a stage 3B cervical cancer, and I ask them, when's the last time you had a pap? And universally they tell me, my last baby, okay? The other thing that to keep in mind for this particular group is the other independent risk factor when it comes to maternity care and that kind of thing is, for some reason, women have now believed that once you have a tubal ligation, that you don't need to be screened either, okay? So because you don't have to come in for contraception, doesn't mean that you don't have to be screened anymore. So we're in the process of trying to re-educate women that because you had a tubal doesn't mean that you can stop seeing your doctor. So that's a very classic example, at least in this state, of how women present with cervical cancer, even in 2015. So when you look at the PAP is really, like I told you earlier, detects these things with very low to moderate sensitivity. It's not very good. But when you look at high-risk HPV testing, It detects all these things with a very high sensitivity, and you'll see how high shortly. But one of the arguments against high-risk HPV testing is that when the sensitivity goes up for a test, oftentimes the specificity or the false positive rate will go down. And so there's a balance there. And so what you'll see is the actual data is that the specificity is actually not as bad as people have criticized it to be. Okay, so this is what I think is really important for this group to understand about cervical cancer screening. So Nassim Taleb is a well-known economist. He likes to write about freakish events that occur in the economic world. He's most famously known for this book called The Black Swan. And in this book, he actually uses an actual SAT question. Thank God that none of us has taken this exam in a long time. But the question is as follows. All zoogles are boogles. You saw a boogle. Is it a zoogle? And the answer is no. Okay? And the reason that this is important is, like I told you earlier, that even though you need a preceding persistent high-risk HPV infection to get cervical cancer, not everyone who has high-risk HPV is going to get cervical cancer. Okay? So we've got to think about the directionality of how that occurs, and that's the teaching that we need to tell women. That you have a woman who is 21, they inadvertently find out they have HPV, it's not going to be at the end of the world for them. That woman actually has up to an 80 to 90% chance of clearing her HPV infection in 2 years. Okay? So again, we're talking about a minority of women who actually develop persistent changes as well as clinical changes like cancer and precancer. Okay? So the two things that I want to point out, of all the technologies that we have today for cervical cancer screening, by far and away, HPV testing is by far the best, and you're going to see a lot of data to prove my point. But here's probably the most single important thing, and something that Dr. Thomas and I have talked about at length multiple times as we try to provide a service and a test that really, in my opinion, serves the needs of our state and the women that we serve in this state. When you have a negative HPV result, that provides you an incredible amount of long-term reassurance that that woman will not get cervical cancer, and that might be over at least 5 years. And with follow-up being an issue in the state, so I oversee the colposcopy clinic at UAB. For those of you that are not familiar with that clinic, we get hundreds of patients sent every year to that clinic. The no-show rate for that clinic is 52%. Okay, so that kind of gives you an idea of what we're dealing with. It would make me feel so much better if I had a woman that came in who had a negative HPV result that didn't follow up for 7 or 8 years than a woman who had a negative PAP who didn't follow up for 7 or 8 years. Okay? So it's about providing that long-term reassurance, and I'm going to show you data on that point earlier. So this is a paper that was just recently published by Julia Gage. She's at the NCI and works with luminaries like Mark Schiffman and Nico Wensenson. But this is from the Kaiser Permanente Northern California group. And there are a couple things I want to point out. On the left is CIN3, and on the right is cancer. Oh, actually, I'm sorry, the pointers came off. But anyway, but what you can see here is the blue curve represents those women that are PAP negative. Looks kind of familiar from that other curve I just showed you, right? But this is U.S. data. The gray curve represents those women that are HPV negative. The red curve represents those women that are co-test negative. I want you to focus on the difference between the blue curve and the gray and the red curve. You can see the clear separation in terms of the detection of CIN3 or cancer over time, over a 5-year period. It's not subtle, okay? So it's not so much that I'm telling you that co-testing is bad and HPV testing is better. What I'm trying to tell you is that HPV testing as a platform is ultimately better for women. What's interesting is that a lot of people will say, well, why don't we just co-test? But the reality is that when you look at the cancer curve on the right, that the actual shaded areas start bleeding over into one another. It's what we call overlapping confidence intervals. So in reality, again, I would ask the question of the group in the audience today, what does really the PAP add above and beyond the HPV test? And this is a classic example of this. And so, and again, this will be an argument that people will have for many, many years, but this slide is really important. I want to point out why we should always consider using an HPV-based strategy over a PAP-based strategy, because you're missing clinically significant disease over time, including cancer. Okay? So again, why is this a better option? And I'm going to get into the data in a second. Again, it's a lot more sensitive and reproducible. You'll see data shortly. But in the yellow, as I put on the slide, it assesses your future risk. And I'm going to just tell you right now, and not going to kind of steal my thunder for the talk, is that in a woman who is type 16 positive, so one of the tests that we're going to talk about actually not just looks at whether or not you're high-risk HPV positive, but whether or not you're positive for certain types. And the two types we get concerned about is type 16 and type 18. If you're persistently positive for type 16, which is the most common type, but is also the worst actor, your lifetime risk of getting cervical cancer for that individual woman is as high as 35%. I want you to think about that number because there's very little that you do, even in the public health world, that carries a 35% lifetime risk. Okay? So, and most things that we see have a risk well less than 10%. And so we're even talking about, well, if a woman is persistently positive for 16 for an extended period of time, should we just go ahead and treat that patient? And right now, I think there's actually a burgeoning amount of data to suggest that that in and of itself should really prompt us to thinking about offering a LEAP or some sort of treatment to that individual patient. But that's not the recommendation, but at least you can say that you heard it here first. So anyway, but so again, why else is it an attractive option? It's highly automated. It can be centralized. The throughput is great. There are actually companies now that are making tests that actually can give you a result in under an hour. So there's even a possibility of a patient who comes to see their OBGYN and get a test, and they actually even know what their HPV status is before they leave the office even, okay? And so it's a lot better. It's and as most things, you don't have to require as much manpower to do the testing. And there are multiple people, including myself, that have demonstrated that it's more cost effective than cytology when you use it as high volume testing, okay? And lastly, and this is the part that I love the most, and you'll see me spend a lot of time on this, is definitely the more logical choice when it comes to screening women against HPV infection. So you'll see more of this in a second, okay? So the slides were slightly reformatted, but I'm going to go. So there are numerous randomized controlled trials, I believe 14 in total, that have looked at the role of HPV testing as a screening test. Some of these studies have been published in the highest impact journals, the New England Journal of Medicine, Lancet Oncology, the Journal of the National Cancer Institute. But in these 14, I'm not going to go over all 14, you kind of get a sense of that these are pretty big studies. And the one I'm going to focus on the most is the ATHENA trial, which is a U.S.-specific trial. Keep in mind that when you do screening studies, you require thousands and thousands of participants to do these trials. And when you do an aggregation of all the study participants on these slides, it's almost 500,000 women that have participated in these trials. Huge, huge numbers, right? Because the outcomes aren't very common. So realize that a lot of effort, a lot of women have gone on these studies. And personally, I think we should be deeply indebted to every single woman that has ever participated in a trial of this nature. So this is the CCAS trial. The CCAS trial, as you see, is the very top one here. This is actually a trial that the senior sponsor is Eduardo Franco. He's the gentleman I showed you earlier in Dr. Papanikolaou's hometown. This is really the first randomized trial that was published in the New England Journal of Medicine almost 8 years ago now that looked at 10,000 women. They were screened in Montreal and St. John's on the northeast side of Canada. And basically they got randomized between PAP and randomized between HPV. This is not a retrospective study. This is not a meta-analysis. This is not a systematic review. This is a genuine randomized controlled trial. Okay? You pick a name out of a hat. Patient goes here, another name on the hat, they go there, okay? So what I want you to focus on is sensitivity for PAP and HPV. 55% versus 95%. It's pretty dramatic, even more dramatic than what we've seen with previous retrospective analyses. What about specificity, that false positive rate? Well, it's actually not as bad as it is because it's been quoted to be as low as 60%. Well, on this trial, it's about 94% for HPV, about 97% for PAP. Okay, so they're not as nearly as many false positives as we initially thought, at least on this trial. What about this issue of consistency? Like, what happens when you look at one lab versus another lab, and when you look at sensitivity and specificity? So what you can see here, in those three bars on the far left under sensitivity is basically the variance between sensitivity between the three PAP labs that happen to do the study for this, happen to do the testing for this study. It's pretty significant when you actually think about it. As high as 75% to as low as 50%. Okay? But what about HPV? Well, there were two labs that did the HPV testing, identical, completely identical, separate sites. Okay? So this is a great example, and this is actually unpublished data that Dr. Franco and Dr. Marin actually shared with me that really classically demonstrates to you all the variance in terms of the performance of cytology when you look at three different laboratories. Okay? It's kind of scary because when you think about a woman who gets a PAP and you send them to a random lab, you're really kind of flipping the coin in terms of what kind of interpretation that you're going to get. Not only are you worried about getting the right interpretation, you're worried about who's reading it. Okay? And so this has been an area of controversy for us for at least the last 10 years. Okay? So if there is one study that I want you to focus on, it's this study. And so Guillermo Ronco, who's an Italian epidemiologist, published this in Lancet at the end of 2013. So this is an aggregate of 4 major European randomized controlled trials for screening, just like the Canadian trial I just showed you. It includes data from the UK, from Italy, from the Netherlands, and from Sweden. Okay? And what you see is on, basically what I want you to focus is on the curve on the right. So these are women who come in with a negative test at entry. And what you can see basically essentially over an 8-year window is the clear separation of the red curve from the teal or blue curve. It's dramatic. And I'll tell you right now, when we do journal clubs and we look at clinical trial design and interpreting data, in the last 5 years I've not ever seen an effect this dramatic. Okay? So what this means yet again is that women, you're missing disease on entry and over time. So the only way that you're going to pick up those women is if they come back. Now, in countries like the UK and the Netherlands and Italy, we can get them back. But we can't get them back here in the US. And so that's why I think this data is really relevant to us. And that's why the reason you don't see the curve nearly go up as high for HPV in the blue is that they're HPV positive, you're examining them, you're picking up disease, and then you're treating them. Right? So you're intervening earlier. And the reason the red curve is higher is that you're not intervening earlier, and then you're missing some cases along the way. Okay? It's kind of scary when you think about it, but this is the reality that we face. So this is a really important trial, probably the single most important paper from Europe on primary HPV screening. So what about for those of you that are interested in rural medicine and developing nations that don't have screening? Well, this is a paper that was published, I can never say his last name because it's got like literally 26 letters, but I would butcher it. Even though people butcher my last name, I got 3 letters. But anyway, he is a well-recognized expert. He works extensively with the World Health Organization. This is a study that was done in India and actually got some criticism, and I'll tell you why it got criticized. A randomized trial of over 130,000 women. By far the largest study ever conducted in the setting of cervical cancer screening. And they actually randomized patients not by patient, but by village. It's what we call cluster randomization. Okay? So they were randomized to 4 different groups. The first group was HPV testing. The second group was pap smears or cytology. The third group was what we call visual inspection on acetic acid. I don't know how many of those know what that is, but it's in essence that you put a vinegar on the cervix like we do for colposcopy. You look for very specific pattern changes. If they have those pattern changes, then you treat them with cryo. And then the fourth one was control, standard of care, which is no screening. So you may have heard some of this. Some of you may have heard this study actually be criticized on like NPR and ABC News because they thought it was really unethical to subject women to no screening when you were screening a bunch of other women on this study. And so it's kind of raised sort of the ethics of doing screening on a study where there's no screening. So anyway, but historically it's very interesting. So again, those with positive screening results underwent colon biopsies, and those who had treatment were given to those with precancerous lesions or cancer. So I don't want to focus on the left, but I want to focus on the right, which is really important. So these are the 2 main curves. So the biggest one is the bottom curve, which is the cumulative mortality. So when you talk to any expert in screening, particularly in the cancer world, the endpoint, it's not about reduction of colpos, it's not about number of visits, it's actually about reducing cancer-related deaths. That's why we screen. So what's interesting about this is I want you to see where cytologic screening is, as well as VIA is, in cumulative mortality. They're actually right below no screening, okay? And I want you to see where you see the orange triangles. That's where HPV testing is. It's well separated from the other three. So up to this point, the World Health Organization has embraced VIA as the standard for cervical cancer control. And this gentleman who published this paper actually published a paper about a year earlier that demonstrated that VIA was definitely the way to go. This paper now shows that this may not be the way to go. And so but the most important point is realizing that if you're going to use a test in a developing nation, that you probably should HPV testing. Okay? And for those of you that are interested in this, since we have the time to talk about it, it is extraordinarily challenging to create a pap smear or cytologic screening program in a developing nation. And the reason for it is it costs a lot of money because you need cytotechnicians and pathologists to read your pap. You need people to process your pap, right? So you need the manpower and the infrastructure to do it. But more importantly, then you also need the mechanism to get them treated, okay? So for a lot of countries, that's just simply impractical, okay? So it becomes a manpower issue and a practicality issue, and this is why there are numerous countries worldwide who simply can't get a pap smear screening up and running. And you have issues with follow-up, and there are cultural issues, but this is the reason why a lot of us are interested in HPV testing, and something that you've probably heard about is something called self-testing. That's why a lot of us are interested in self-testing using the HPV platform. But this is a really great study because it really clearly demonstrates that really of all the technologies that we have, HPV testing is definitely the way to go. So let's break away from countries like India, developing nations, and talk about our own developing nation of the U.S. So this is a study that was published by Horswood Kaki, who is a statistician at the NCI, published this in Lancet Oncology in 2011. So this is from that same group of the Kaiser Permanente Northern California group, basically in Sacramento. They have by far the largest cohort of screened women in the United States. And what's a plus and also a minus is a lot of our screening and treatment decisions are informed on this one population data set. They actually have well over 1 million women screened at this point. And so people have argued, well, this population is not representative of what we see in community X. And I've argued that this population is definitely not representative of the population in the state of Alabama. So you have to take some things a little bit with a grain of salt and recognize that, you have to compare apples to apples and oranges to oranges. But at least it kind of gives us an idea of what you would see in a reasonably well-screened average risk population. Okay? So, 3 really important data points here. Okay? So for all women who have a normal pap test, the rate of cervical cancer in this population was 7.5 cancers per 100,000 women per year. What is it for HPV negative women? It's half that. 3.8 cervical cancers per 100,000 women per year. Okay? So I know you're dying to know what is it for normal pap and normal HPV. It only drops down to 3.2. Okay? So go back again. It's 7.5 for normal pap, 3.8 for negative HPV, 3.2 for normal pap and negative HPV. So really not that much of a difference. Okay? Just think about it. Again, what does the pap add above and beyond the HPV test? Okay? So what if you look at the different combinations? What happens when they get a positive pap or positive HPV, negative HPV? I want you to focus on the bottom right, 2 last rows, where it says HPV negative, pap positive, HPV negative, pap negative. So these are women that have a normal pap test, but women who might have either an abnormal pap test or a normal pap test. The excess risk in that combination is less than 1%. Okay? So again, it doesn't matter if you have a positive pap. What matters is that you have a negative HPV. Okay? On the flip side, when you look in the upper right, for women who are positive HPV and negative HPV, the excess risk is over 7%. Okay? So what this means to me, and it should mean to you all, is the excess risk is driven by the HPV test, not driven by the Pap test. That makes sense? So, I mean, that's really this is why I think this paper is so critically important to our understanding of the various components of cervical cancer screening. So let's talk about the ATHENA trial. So ATHENA stands for Addressing the Need for Advanced HPV Diagnostics. This was in a huge 43,000 patient study done in the United States, the largest cervical cancer screening ever conducted in the U.S. in the setting of cervical cancer screening. And basically, it was an FDA registration trial. Yes, it's an industry-funded trial, but I can tell you that this company went out of its way to consult with all of the worldwide experts in terms of how to design the right trial, and they did an absolute amazing job doing that. So they enrolled 47,000 women, and so 3 years ago they got FDA approval for ASCCP triage and co-testing, and actually UAB switched over to this platform a couple years ago. But they actually presented what we call a primary HPV screening claim. They went to the FDA and said, you know, we think that we have a test that could be used for primary HPV screening. And they created an algorithm, and they actually presented this to the FDA, and there was an expert panel of 13 people who are literally experts in diagnostics and cervical cancer screening and screening in general, and they unanimously voted in favor of primary HPV screening on the 12th of March 2014. It was actually at that meeting. I went because I thought it was like a very, seminal event in women's healthcare, much like the pill. And so I actually wanted to be there to hear the discussion and kind of hear the vote. And it was a very, very interesting discussion. It was actually held in Maryland, right outside the Metro D.C. area. And then about a month later, on April 24th, the FDA released this news release that basically proved the first HPV test ever for primary HPV screening. Now, the reason this is important, you're like, well, yeah, that's neat, so what? But the reason this is important is the rest of the world has been leaps and bounds ahead of us. I've shown you all that data I just showed you from those trials. 90% of it comes from Europe. It doesn't come from the United States. And so we all thought that the US was going to leapfrog us and basically beat us in terms of providing the best screening mechanism to their women. And this became a big deal because, for those who don't recognize it, a good chunk of the world, they look to the FDA to guide them to make treatment decisions for their patient populations in their country. So an FDA news release isn't just specific to the U.S., it's specific to many, many countries worldwide. And as a consequence to this, so I and others, and some of these people you may recognize, people including Debbie Saslow, who works at the American Cancer Society and does the screening guidelines for cervix and breasts, Mark Schiffman, who is and Nico Wensenson, who are well-known luminaries and experts at the NCI, Walter Kinney, who is the lead author for the Kaiser Permanente Northern California group, Herschel Lawson, who represents the chief medical officer for the ASCCP. We knew about this. We knew about their application. It was public, but we knew that once they got FDA approval, that you all would want some clinical guidance about how to use the tests. So we did this in parallel with Roche. So we did this separately. We had access to all the Roche data, and we basically came up with our own guidance and guidelines to guide you all about how to use this type of testing. So this is the reason why we published this document. So a couple things I want to point out. These are slides that actually were taken straight out of the FDA presentation, so I wanted you to see what the panelists saw. But when you look at the 3-year risk, okay, for women who are getting screened with CIN3 or worse, you can see how HPV-16 is much, much higher than 18, the other 12 high-risk types, and obviously women who are HPV negative. If you took that curve and you plotted it over a 5, 7, 10-year window, it would gradually creep up to about 30 to 35%, okay? But it's already 25% at 3 years of follow-up. 1 in 4 women, just think about this, 1 in 4 women who are persistently positive for a 16 or a 60 positive period will have CIN3 or cancer. It's a pretty dramatically high number. So when I talk about risk, that future risk, this is where we're going to be. We're talking about how to best counsel women, not just for today, but for the next months or years. So this is the actual algorithm, and you'll see it later at the end of the talk. You have to use this COBOS test, which is made by Roche. If you're HPV negative, you go to routine screening. The test tests whether or not you're positive or negative, and if you're positive, it also tests whether or not you're 16 and 18 positive. If you're positive for 16 and 18, you would go to Colpo. And then if you test positive for the 12 other high-risk types, you get triage to cytology. So when this first got approved, the New York Times, the Wall Street Journal, the Washington Post were all saying, oh, the pap smear is going away. The pap smear is not going away. You know, the pap smear is being better used in this setting. And so it's what I call this concept of enrichment. You know, I told you that sensitivity, that false negative rate was 50%. Well, if there's a higher rate of abnormalities going to cytology, that test is going to work a whole lot better. Okay? So I want you to look at this paradigm. Okay? And so many of you work in the public health setting doing screening, not just for cancer, but for infectious diseases. I don't know of any other circumstance in modern medicine where we use a less sensitive test first, followed by a more in other words, we use the least sensitive, the more specific test first, and a less sensitive test second, right? So I'll give you an example. HIV testing. You use the most sensitive test first. If they test positive, and you validate it with the most specific test positive. Syphilis, the exact same thing. In this circumstance, we're doing it the other way around. Okay, we're doing it backwards. And so what we should be doing is the more sensitive test first, followed by the more specific test second, which is cytology. Okay? So we're just following common sense here. But for so many years, we've been doing it backwards. So one of the criticisms is that this algorithm was approved for women 25 years and older. And so you've been taught by people, including me, that the prevalence of HPV is extraordinarily high, particularly in younger women in their low 20s, that HPV is common, and that if you treat all HPV-positive women, you're going to overtreat, etc. And there's no question in this strategy that when you look at women between 25 and 29 years of age, if we do primary HPV screening, you will wind up doubling the number of colposcopies. Okay? You're like, well, that doesn't sound very good, right? And there's no change, essentially, in women who are 30 years and older. But there are two pieces of data that I want you to think about. And you might sit on different sides of the fence. Don't let me persuade you, but just think about this. So on this trial, what we learned is that almost a third of all CIN3 cases occurred in women between 25 and 29 years of age. Much, much higher than we ever recognized. To put this into even greater context, this patient population that was in ATHENA is what I would categorize as a very low-risk population. It's a population that got screened every year. It's not the state of Alabama. You know, it's not the various counties that we serve. Certainly not our colposcopy clinic. Okay, but again, this represents a very low-risk population. Almost a third of these cases occurred in 25 to 29 years of age. Okay. Well, here's the thing that's really fascinating. In that 25 to 29 year age bracket, almost 60% of them had a preceding normal pap. Okay. So I would ask the group in front of me as well as the audience listening in, we are definitely missing a lot of disease with our screening. Okay, so the questions you should be asking is it clinically relevant? I don't know if it's clinically relevant. Is CIN3 in a woman who's 27 different than a woman who's 37? Possibly. But our job as screeners and as clinicians and as advocates for public health care is to pick up disease, eradicate that disease so they don't get cancer. Okay, and so, again, a third, 25 to 29 of those cases occur in 25 to 29 years of age, and 60% of those cases have had a preceding normal pap, the majority. You know, and that's why the panel, this is what they argued for about 5 hours, but they ultimately voted unanimously in favor of starting at 25 years of age with this type of testing. Okay. So is screening needed after vaccination? Absolutely. So the current quadrivalent or bivalent vaccine includes protection against 16 and 18. I've already told you that they're common, they're bad actors, and actually may protect up to 75% of all cervical cancers. But the problem is there's a 25 to 30% window. That's why we teach women that you need to continue to screen, and it's why you can't tell women and girls that because you're getting vaccinated, you're fully protected. You can't tell them that. And that's a major concern and a major limitation. And one of the major criticisms when we rolled out vaccination was like, how much more money could we spend on cervical cancer prevention, but I think we all see the value in this because it's not just in girls, it's also in boys, and there are other cancers as well. So one of the joys that I have as being sort of a quote-unquote expert in HPV is I go to a lot of HPV meetings internationally in the United States. And so I was looking at posters and walked by this poster, and I took a 180 and came back. I said, "You have got to be kidding me." And I was like, "Unvaccinated backpackers will spread genital warts in Australia." And I thought this was a joke. I thought this was an abstract that kind of made it under the radar. But it actually is a brilliant, brilliant abstract because it talks about disease transmission and what that looks like in a country like Australia. And I got to meet Basil Donovan, who's the lead author on this, senior author on this. And I'm going to show you something that I think is truly fascinating for this group. I'm not here to soapbox about why women or men and boys and girls should be vaccinated, but I want you to hear the story very carefully. So, is vaccination a political thing? It's absolutely 100% political. And actually, just telling Dr. Thomas that I presented this exact presentation at the United Nations building up in New York City last week, and obviously politics is a very hot word, very hot potato word, but I went out of my way to make sure that they knew this was political. So the gentleman on the right is Ian Fraser. Ian Fraser is one of the 4 iconic inventors of the HPV vaccine. He's Australian. He's a very soft-spoken, self-effacing man. And on the bottom right is an actual magazine cover. It's their version of Time magazine's Man or Women of the Year. And this is literally what it said, God's gift to women. He hates this cover, by the way, right? Because he's not like that. He's a really, really quiet, wonderful gentleman. So the vaccine gets approved in 2006 in Australia, like it just did in the United States. And you have this iconic inventor, Australian Man of the Year, and then their immunization program, or their version of the ACIP, rejects it, right? It's like, how could that be, right? This is something that the Australians should rally around because it's such an incredible achievement. Make it even crazier, it was an election year with a surplus budget. The country was doing really well. And supposedly the health minister at that time had a really negative, dubious reputation in women's health. Okay? Kind of, not the greatest situation. But then this gets really interesting, is that the first lady of the prime minister actually had a history of cervical cancer. Went out of her way to completely destigmatize the disease, obviously massively influenced her husband for positive reasons, right? And the rest is history. And what you'll see why is the rest of history. And so in the bottom right, you'll see John Howard and Jeanette Howard, who I'm referring to, as well as Tony Blair and his wife. And you guys remember Tony Blair, who's the former Prime Minister of the United Kingdom back then. But these are the kind of changes that are required to make a real influence. And so if you're a woman starting about 2007, it would be impossible for you not to see one of these articles and these campaigns at a bus stop, at a coffee shop, at a bathroom, at a bar, that they had the most aggressive campaign. They had school programs that promoted vaccination, community-based programs that vaccinated older women, and in 2015, they have like an 83% vaccination rate in their country. It's really impressive. And obviously I can't poll the people here, but in this country, for those that are interested, based on the most recent national immunization survey, that rate for one dose is 37%. Okay? It's abysmal. It's shocking, and I think it's really bad that our country doesn't do a better job. And I'm hoping with things like the whole measles outbreak in Southern California and Ebola and the flu, that you think that we would have a better understanding and appreciation of vaccination. So where are we now? And so Dr. Ali, with Dr. Donovan, who's actually on this paper as the second author, basically published what happens in their population in terms of genital warts. So when we look at HPV vaccination, we have 3 main targets. We have an early, mid, and late target. The early target is warts because it's caused by 6 and 11. The middle target is cervical dysplasia or precancer. The late target is cancer. The reason it's early is because warts happen very quickly, and the reason late for cancer because it takes a generation to figure that out. Okay? So I want you to keep in mind that this is 5 years into their vaccine program, starting in 2007, only girls and young women, not boys. Okay? What they saw 2007 to 2011 in women under 21 years of age is a 93% reduction in genital warts. And when I talked to Dr. Donovan last year, who was the presidential speaker at our ASCCP meeting, that number is up to 98%. okay? It's impressive, okay? And we're seeing the exact same data for high-grade dysplasia in that country, exactly the same, okay? And unfortunately didn't have the time to include that. But when you see women 21 to 30 years of age, some of them who got vaccinated, about a 75% drop, so still impressive. And women over 30, none of which you got vaccinated, you didn't see any decline. Okay, so, you know, if we need proof, this is the proof, and I gotta tell you, I think this is the most amazing success story of one individual country. It's a big island to the southwest of us, but honestly, they have done an incredible job at reducing rates and have shown unequivocally what HPV vaccination can do for their population. What about boys? Right? What about boys? Remember I told you that boys didn't get vaccinated, okay? But there's this concept of something called herd immunity. It's actually a veterinary term, and what herd immunity is all about is if you vaccinate a population to a certain threshold, 75%, 80%, you wind up conferring immunity to the unvaccinated fraction of that population. So again, keep in mind that vaccination is the first public health effort that any born child does, the first thing that they ever do in this world. When they get vaccinated, you don't realize you're not protecting them, you're protecting their community. And that's the thing about vaccination. I think we've forgotten about that element. But what about men? Well, in men, what we saw is up to an 80% decline in warts in basically young men. And no, you really didn't see the same decline in older men. Okay? So we're conferring protection in girls that we see in boys if you wind up vaccinating the majority of women and girls in a certain population. But in this population, we offer it to men and girls. They do in Australia too. I want you to see scientifically what happens on a population level, okay? So why is this all important? So why would you probably think this is a primary HPV screen lecture. Why am I talking about vaccination? Well, anyone in the public health world recognizes that positive predictive value for a test is highly contingent upon the prevalence of the disease. So if the prevalence of the disease goes down, your positive predictive value goes down with it. And this is a great graph that I actually got permission from Eduardo to publish and show on my presentation. So as you can see in the blue curve, which is positive predictive value, when you go from right to left and the prevalence gets smaller, you can see the positive predictive value, which might start off in the 80 to 90% range, that just plummets. You see that? Okay, so you should be reading the blue curve from right to left, not from left to right, if that makes sense. Okay, so I'm going to put this into context for you all. Okay, this is like actually what we would see in the United States. If the prevalence of HPV in this country, in the United States in 2015, is roughly 20%, it might be a little bit higher than that, okay? That's where you are in the curve today, okay? So if you vaccinated at a 50% level, which we're not at yet, you'll see where we are on the curve then. It drops in half the prevalence, right? What happens if you go to 75%? You see where we are on the curve now, okay? This is why it's really important for us to think about adopting new screening paradigms today, because literally if we think about it tomorrow or 5 years from now, we're literally going to get caught with our pants down, because right now, unfortunately, we're going to be on that steep part of the curve where the positive predictive value may be only 30 or 40%. Okay? So this is a great real-world example of why prevalence of disease is so important to the positive predictive value. Okay? But I recognize this, so for those of you that recommend screening at the respective health departments, you know, we have two recommended screening strategies. Cytology, or PAP, every 3 years. Co-testing every 5 years in women 30 and older. Now we got a third strategy, and I get it, it's confusing. And I think that Mark Schiffman and I have talked about this, but, you know, he's like, we have this great data, and we need to get it to clinicians, and all I hear is, it's just too confusing. And I've embraced this concept of simplicity. He's embraced this concept of precision and data. And he and I have just recently met in the middle. But when you think about the greatest public health interventions and messaging, they've always been simple. Buckle your seatbelt. Quit smoking. Get screened. And I think that we are actually having the inadvertent effect of making screening more difficult than it needs to be. So this is a great example. So Mona Soraya, who I think some of you might even know, is an OBGYN at the CDC in Atlanta, is an OBGYN but doesn't practice OBGYN anymore, published this survey data back in 2006, 2007. But anyway, a couple things that are really interesting. In the survey, 60% of women with an HSIL PAP got HPV testing. Right? You guys have been taught that there's no role for that. Okay? What's even scarier is that women under the age of 30, almost half of them got HPV testing when we told you specifically not to do that. Okay? Now, part of this is to be blamed on the labs, because the labs will just do whatever they want, even though they're not supposed to. Or maybe you just checked the box, you didn't realize what you were checking. But regardless, what this means is that we have a long ways to go in regards to education. I get that. I'm a huge advocate of that. And trust me that there are people fighting for you in terms of not making your guidelines more complicated. But again, that's a work in progress. Okay, so again, I'm going to close with a couple things. This is the actual algorithm that is FDA approved. This is actually out of the guideline paper that I published with my co-experts. Okay, and again, the value is the whole genotyping of 16 and 18, and that if you're negative, you can be referred back to routine screening. But this is actually in the paper itself. So my recommendations to you is this. These are the things that you should think about when you think about screening. When you have a negative HPV test, I feel a lot better about that patient going out than I do for a woman who has a negative PAP test, unequivocally. And there isn't an expert in this world who can counter otherwise, because the risk is that much lower. We've even talked about in developing nations that really, in reality, a woman probably only needs one screening test in her lifetime at 35 years of age and just one HPV test. If it's negative, their lifetime risk of getting cervical cancer is incredibly small. That's the power of that test. Okay? We've actually demonstrated that this can be used as an alternative to cytology. It's worded this way because we didn't want to throw cytology under the bus, but clearly we think that HPV testing is much better than PAP for the reasons that I've shown over and over again from various different angles, US, worldwide, historical. A lot more reproducible, okay? Again, the negative test is really important here and definitely more sensitive than cytology. It picks up more at most women with precancers, okay? But what are the concerns? It's important to be balanced here, is that there are 3 screening options. You're more confused. We don't know how to screen how often for primary HPV. It's just too early. It's set at 3 years. Maybe you see that as a positive. I see it as a positive. Maybe someone wants to ask that question, and I can expound on it further. How does it compare to co-testing? Well, probably there's very little difference. But again, the question is, how much more protection do you need? And really, for systems that are cash-strapped and we have tight budgets, do we really need the PAP? And that's what we really should be asking for ourselves. What about this concern of overtreatment between 25 and 29 years of age? This is a real concern. And one thing that we did discuss is that you might miss cases where the woman has a normal negative HPV result but an abnormal PAP. And the prediction for that may be as high as 10%. It may be as low as 1%. We just don't really know what that value really is. Okay? I'm going to go over this very quickly. I've already talked about this. A lot of the data is consistent, restricted to women above the age of 30. And again, I would argue that primary screening is really only appropriate for really organized screening programs. And this is the problem with screening. You can't move the needle if you only offer screening and don't have treatment, right? So if we had a state like Alabama where all we did is screen everybody, but they had nowhere to go with their abnormalities, it would be the same issue, okay? So you got to offer a treatment piece as well as the screening piece, okay? And again, the reflex test, whether it's PAP, genotyping, we really don't know where it is, what the best test is. And as I mentioned to you earlier, most of these studies are from Europe, and there's only one U.S.-specific study. Okay, but this is really where the kind of rubber hits the road, and this is what women and clinicians really think about this guideline as well as our recent guidelines. And these are actually actual quotes that I've been collecting for this talk, right? It's too confusing, too many changes at once. That actually came from a nurse practitioner. This is all about money. That actually came from one of my patients. The PAPs are going away. I'm worried about increasing the screen intervals. And as one of my very famous patients told me, is I cannot believe you're taking my PAP away. Okay? And they, for some reason, feel that their PAP is it's like the epicenter of their gynecologic care, which to the doctor it is too. And so they feel like you take the PAP away, you take away their gynecologic care. And so it's great that we have taught women and their mothers and grandmothers to tell them get a PAP every year, but it's like breaking a bad habit. And so, and unfortunately, you know, it's tough to teach them that. And so, you know, when they hear about HPV, they hear about sex, and they don't think about cancer. And so we have a lot of ways to go in terms of education. So anyway, a lot of the references here that I can cite, and you can actually pull them off. Be more than happy to send you the full reference list. But that's the end of my presentation, and it was an honor. And thank you, Thomas, again for the opportunity to speak. Thank you very much.
Well, thank you, Dr. Ha, for being here and for again presenting a compelling and provocative presentation. It's always a joy to hear you speak on HPV and screening. Are there any questions, Nancy?
Not coming in with the email, no.
Okay. Warner, one question I think that I'd like to ask is, we know that the majority of cervical cancers are type 16 and 18, about 70% or more here in the United States, and probably the same worldwide. What about cancers that are not, cervical cancers that are not HPV related?
Right, and that's what I was referring to about that 10%. So we originally thought, and still do believe, that 99% of cancers will have, cervical cancers will have identifiable fragments of HPV. But there is registry data through the CDC in the United States that indicates that perhaps 10% of cancers, cervical cancers in the U.S. are HPV negative. And so undoubtedly, you're going to miss some cancers that might have been picked up on PAP, that may not have picked up on HPV. I think 10% is really the upper limit of that number. You know, I think the one thing to recognize, and this is a really hard concept to teach the lay public as well as a lot of doctors, is that the goal of screening is not to pick up every single case of cancer, because that's impossible. You know, we have cases of mammography and breast cancer screening in this country where we still miss breast cancer. But the key is to pick up cancer or pick up, you know, a pre-invasive lesion to prevent mortality from cancer, but also do it in a manner that does not negatively impact a woman's quality of life. And so, yes, that is the concern, but I would say that of the 10%, if it's that high of HPV negative cervical cancers, the value of primary HPV screening greatly offsets that. It's not even a close comparison. But it's a question that comes up constantly and one that does concern me. But again, I would argue you're missing a lot more cancers with PAP alone than you are with HPV. So,
thank you. Any questions from the audience?
I would like to ask a question, Dr. Hutt, and it's sort of maybe along the same lines, but you have a 42-year-old woman, say, and she has a low grade with a negative HPV. And there's two arms, I understand, to that treatment process. You can either co-test again in 24 months, or in 12 months, or you can send for colposcopy. Mm-hmm. And I think UAB and our policy right now is to send for colposcopy. And when we're sending patients out, sometimes the doctors are sending notes back that, you know, we should just co-test again in 12 months. So what are the pros and cons to those two arms, and just sort of expound on that a little bit for us, if you don't mind.
That's a good question. The question is that how do you best manage a woman who is L-sil HPV negative? And you're right, there are two different management strategies. One is to repeat their co-testing at 1 year, or the second strategy is to go straight to colposcopy. There's no question that the risk of a clinically significant lesion in a woman who has L-sil and HPV negative it's very small. It's like in the single-digit range, but it's not zero. Okay, and so this is kind of where we have to make a on-the-fly call in Colpo Clinic, because the number one concern that we have about patients when they come in is not their risk of disease currently or later. It's about whether or not they're going to follow up. Okay, and so there are certain patients who, you know, and this is not an exact science, who we know are going to probably follow up more regularly, and there are some patients who we just recognize. So, for instance, that risk is a lot higher as you get older. That risk is lower as you're younger, and so there are a lot of factors that go into it. I'm glad you raised that, because in general in that patient population, we probably should be using Colpo more regularly than follow-up. But there is a role for follow-up, because not all patients are not going to come back in. And so I'm certain that there are certain decisions that are made along those lines. So I don't know if that answers your question.
Thank
Yeah.
We actually have a phone call that would like to ask a question from Georgia. Go ahead with your question.
I'd like to know what the concerns are for a patient who has had a positive HPV test in the past and is post-hysterectomy, possibly with residual cervix left after surgery. We've had a situation like that we've dealt with and are actively following that. I just wanted to know his ideas about that patient.
Right. And so it's a great question. And so what's currently recommended is in a woman who essentially has normal screening in the past or has had 3 consecutive normal screening tests and undergoes a hysterectomy, we're not just asking, we're like begging clinicians to stop screening, right? Because the risk of getting vaginal cancer is essentially 0%. But in the circumstance that you're describing, it's different because that woman still has a cervix, right? And so she has what we describe as a subtotal or supracervical hysterectomy. So that woman still needs to be screened, just like if she didn't have a hysterectomy. Now, and so it's, and after 65 years of age, if that woman has had normal screening, you can stop screening at that point. Again, the presence or absence of HPV shouldn't drive whether or not you should continue screening. What should continue and drive their screening is their previous screening history over multiple tests, their age, whether or not they've had a total hysterectomy. Those are the things that we factor in. But in a woman who's had a supracervical hysterectomy, even if she's had a distant history of an abnormal test or a positive HPV result, you should screen them based off of basically regular guidelines as though they never had the hysterectomy. And we're seeing a lot of these patients now. We're seeing a lot of patients who have had a supracervical hysterectomy, their cervix is in situ, and they have the abnormalities, and it becomes a little bit of a challenge because it's not exactly the same as a woman who has a fully intact uterus. But I'm not sure if that answers your question, but so again, a woman who's had a supracervical hysterectomy, we're not lumping those women into the same hysterectomy recommendations in terms of cessation of screening after a full hysterectomy.
Well, in our situation, the patient, felt like, she had documentation of a, total hysterectomy. So the only reason we knew that there was a LGFIL was the fact that her physician chose to continue her PAP after a hysterectomy. And then she was found with a low-grade lesion that
Right.
had to have follow-up, and on MRI, she had a residual sliver of cervix.
Yeah, obviously it's one of those nuanced cases. If you're asking me honestly, that the overall risk of that woman developing vaginal cancer is so low, it's extremely small. One thing and to your point, one thing that we're about to publish in the next 6 months is how to manage an abnormal vaginal pap smear after they've had a hysterectomy in women who have inadvertently been screened. Because even though we teach not to screen, we still have got to provide some guidance. And so I can't tell you what's going to actually be in the final document, but there might be information that in a woman who has an LSIL pap, we may still tell you to stop screening altogether. Okay? And so, but in your circumstance, in a woman that has, a sliver is kind of hard to define, but in that circumstance, I think that once you've started that testing, I think you're obligated to follow up that testing, unfortunately. But to somehow get that patient off screening, if she had a continuous LSIL pap smear, because again, that risk is so small. I'm not sure if that fully answers your question or not. So.
Yeah. Thank you.
I've got another question. I think the evidence that you presented for HPV as a primary screen is certainly compelling, and I think when you think in terms of assessing future risk, it's the science is there, and when you think also of the lifetime risk of 35%, for women who are HPV type 16 positive, that to me as a clinician really piques my interest. Mm-hmm. How do we integrate HPV as a primary screening tool into practice, and how do we educate patients as to this other option? What are your colleagues and counterparts saying in that regard?
Well, what's exciting is, at least at UAB, the general OBGYN group at UAB has made a administrative decision to offer primary HPV screening as the primary modality of screening to all their women. But the caveat is they wanted to do it stepwise to understand the value, so they're going to start at 30 years of age and not at 25. But I think once they understand this, I do believe that they'll eventually roll it out to 25 years of age. And the question is why? Why did they do it? Well, they did it for the exact reasons that we talked about today, which is they saw there being tremendous value in terms of telling a woman that they're HPV negative in terms of their protection against cervical cancer. And so, we talk about you're positive, what those implications are, but keep in mind that the majority of women in this country, probably 85 to 90% of them, will test negative. They won't test positive. And so when you're going to tell that bunch of women that they're negative, I personally think that you should tell them that they're legitimately negative and that they have nothing to worry about. And I think that we have sort of mistakenly assumed the value and the protection of a negative PAP. Because as you know, women don't come back every year now. They come back every 3 years. And so what I tell clinicians is that I think there's a lot of power in terms of telling an individual woman that they've got this tiny, tiny risk of getting cervical cancer after a negative HPV result. That's what screening should be all about, that negative predictive value. So,
thank you.
We do have one question via email. The question is there an IRB that's used in India?
Well, I think there was an IRB that was used. I don't want to say this definitively, but that in a trial like that, there are certain guidance, worldwide guidance, that really expects and mandates that you use an IRB. And so, but even trials that get IRB approval still raise eyebrows and concerns. So an IRB approval is not a guaranteed protection of creating a questionable clinical trial. Unfortunately, we've seen that in this state as well. And so, but I'm pretty confident they used an IRB for a trial of that nature. So.
Well, I've got one last question. You wanted to expand earlier regarding the interval screening.
Yeah.
Can we talk a little bit about that?
Yeah, that's actually a great point. And I think for the audience, this is actually really good for them to hear. These are my opinions and my opinions alone, but hopefully, I'll back them up with reasonable data. So the current screening guidelines in this country are every 5 years with co-testing, every 3 years with cytology. I mean, Dr. Thomas, you and I probably remember that not so long ago that we were screening every year, and that was acceptable. And all of a sudden, 5 years, to me, seems like a quantum leap. And so when we voted on this in 2012 with the American Cancer Society, the ASCCP, and the American Society of Clinical Pathology, the end point for screening at that time was really the reduction of colposcopies. Not mortality, lives saved, morbidity, but reduction of colposcopy. And so there was a lot of controversy about whether or not that was the right endpoint. And some of us in the room didn't vote in favor of a 5-year interval. Okay? So recently, this past year, I, with Walter Kinney and Tom Wright and some other individuals, including the current president of ACOG, we published an editorial which I would encourage that everyone read, because it's a discussion piece that really raises the issue that we have shown through data sets that as you increase the screening interval, you raise the rate of cancer. It's unequivocal. So in the Kaiser data set, if you go from 1 year to 3 years to 5 years, that rate, annualized incidence of cancer, goes up. You miss cancers. My concern is really more of a pragmatic one, in that if I tell a woman to come back every 5 years, I honestly, as a doctor, can't remember what I did 5 years ago. If you ask me what I did in my healthcare 5 years ago, I would have no way of telling you. Our EMR and notification systems are not up to snuff to be able to tell women that they need to be screened. So my concern is 3 years or 5 years becomes 6, 7, 8 years. And so I think the screening interval is too long. It may be right, as we vaccinate more and more women, but I think we got to do this incrementally. I think 5 years was way too big of a jump too quickly. And so that's why I think that you're about to see, as the United States Preventive Services Task Force is now just visiting the research plan for their cervical cancer screening guidelines, one of the major agenda items on that research plan is intervals, and whether or not A, is it the right endpoint, and or B, is perhaps 5 years too long. And so I think, honestly, we will have done a disservice to this country if we recognize, 5+ years from now, that all of a sudden that the incidence of cervical cancer is going up and not going down. And then we're going to say, well, we used the wrong endpoint. We used colposcopy as an endpoint when that's not really the right endpoint. So I think there are a lot of women who have been fine with getting a colposcopy as if it prevented them from getting cervical cancer. So.
Thank you. Nancy?
Okay. Since we have no more questions and no more emails, I would like to thank you, Dr. Huh, and you, Dr. Thomas, for joining us today. Remember that this presentation is available on demand on the ADPH website. I believe it's below on your screen. And please, thank you for being here and have a good day.